and I started sooner. Sorry about that. So we're going to record the session. I'll send out the link after tonight with the follow-up information, as well as the links to join our future programs. If you have any questions or comments during the presentation, feel free to throw it in the chat box. Make sure that you're sending it to everyone in the meeting so we can see. And I'll make sure to keep an eye on it and ask Dr. Jamieson the questions as they come in or at the end. Okay.
Perfect. Let me see if I can find my thing now.
Yeah. Sorry, I made you close it.
Now let me see where it went. Hold on. Sorry. Technical difficulties. I'm better at hip and knee replacements than I am Zoom, evidently.
Zoom is hard, just in general. We do see your screen.
Yeah, let me see where that went. It is right here.
Oh, looks like it's okay.
There we go.
There it is. Awesome.
Yeah, perfect. All right. Can you see me?
Yep.
Perfect. All right. Well, Grace, thanks so much. I am super excited to be here. I am really, truly grateful for the work that the Arthritis Foundation does. I've been able to work with these guys for, I don't know, probably the last 8 years or so. And so I've seen them grow. They've done a ton of work on the rheumatology side of things, ton of effort, and it's been awesome, especially with our kids with juvenile rheumatoid arthritis. But I deal mostly with osteoarthritis. And so we've talked for a lot of years about really making sure that we're touching base with the osteoarthritis patients as well, which is what I typically see on a daily basis. Recently that's kind of been a bigger push, and I'm super excited about where the Arthritis Foundation is and where it's going. We've been able to do a lot of work with the Jingle Bell Run, which is a ton of fun. Taking my family, my office, we end up all going and having a great time. So I appreciate Grace and Heather and all the people that work with the Arthritis Foundation and for the opportunity to do this tonight. So kind of the format tonight is I do want you to ask questions, put it in that chat bar. But at the end as well, I'm going to talk for about probably 20, 30 minutes. And then at the end, you can ask any questions and we'll go through it. This title is kind of hip and knee replacement, but it all deals with arthritis. And I will talk about that here in just a second. But let me see why it's not moving forward here. There we go. So I, like Grace said, I'm in Northern California in Roseville, California. So some of you from local, that's where we're at. But I like to at the start just kind of tell you a little bit about me, and that way hopefully it's a little more personal as we go through this, and you feel more comfortable even asking questions. But I was born in Reno, Nevada, which for us isn't too far away here in Northern California, but I moved to Texas when I was little. This was a bumper sticker that was frequently seen. I definitely have a lot of Texas pride or confidence or whatever it is, but I actually really, really love California. I love being here. So I went to BYU out in Utah and voted one of the prettiest campuses in the country, right at the base of the mountains there. And then lived in Italy for 2 years up in the whole Northwest corner and just loved my time there. So I'm fluent in Italian, which doesn't help me too much in California, but every once in a while I have an Italian patient. Finished undergrad at University of Colorado in Denver and medical school. So there's 2 of my babies that we had, one right before med school and one during, and then went up to Michigan State to do my residency. I was there for 5 years and just had some great trainers, great people that I worked with, and great co-residents. I loved my time up there. But then went down to Los Angeles and did a fellowship specifically in joint replacement. So hip and knee replacements were my primary, and did revisions, did all kinds of stuff. So these were some of the things. This was actually a rheumatology patient. I did a lot of work with rheumatoid arthritis patients in my fellowship down in Los Angeles. We had a lot of them, and it just really destroyed the joint. I talk to patients all the time. They talk about how expensive medications are, and they say, they're so expensive. Why? And everybody's out to make money. And I think rheumatology and rheumatoid arthritis specifically has probably seen the most advancements because of the research and development that's gone into medications in the anti-rheumatic medications. We used to see I used to see patients on a daily basis that had rheumatoid arthritis, that their joints were just destroyed. And because of a lot of these medications, because of things like the Arthritis Foundation and the research and development that went into a lot of these, we really have seen a lot of joints saved because of the medications, which has been amazing and super helpful for our rheumatoid patients, and grateful for that. But so I mostly do hip and knee replacements now. But again, this talk is going to be a lot just on arthritis, and then kind of where hip and knee replacements are. I can speak a little bit on, other replacements if you have questions on that too. But I don't typically do those in my practice. Revisions, some knee scope stuff, a lot of work on navigation robotics. And we'll talk a little bit about where those are at in joint replacement today as well. And then some other things too with work comp and med legal. Let me see. All right. So other things, I do a lot of things, rapid recovery, pain management around surgery. I think that's a big area that we've really worked on and done a lot of growth in. It used to be that we'd keep patients in the hospital 3 to 5 days. And now most of them are, most patients go home that same day. And we'll talk a lot about that. I was actually at a meeting where we had kind of this emeritus speaker. He was in his early 90s, and he'd been part of the orthopedic community for a lot of years. And he said he remembered when the beginning, where when he was first started training, that patients would stay in the hospital for 6 months after joint replacement because we didn't know what would happen. If patients would survive, if they die, or what would happen with it. So then he says he remembers when it went to 3 months, and he thought, man, a lot of patients are going to die. They may reject this, or then it went to a month, and then 2 weeks, and then 3 to 5 days, and now really most patients go home that same day or overnight. But so outpatient total joint's a big one. I'm doing a lot of work, and we're really trying to do a lot of work to decrease narcotics after joint replacement too. So really there's a lot of advancements going in a lot of these areas. So last few things about me. I am a fan of the Dallas Cowboys, growing up in Texas. Not super popular here in Northern California. There's a lot of 49ers fans, but they do accept me. And then enjoy the Kings, but I do a lot of water skiing, so a lot of stuff on the water here in Northern California. And then there's my kids there. So they're a lot older than this. This is a pretty old picture, but my oldest is just graduated from high school and taking her to college here in about 2 or 3 weeks out in Idaho. So really excited about that too. So really this talk is going to be answer a few questions. What is arthritis? Who gets arthritis? Why do they get arthritis? And then where can you get arthritis? How do you prevent arthritis? And then what do you do if you have arthritis? And we'll focus a little bit more on osteoarthritis. But if you break that down, arthritis, arthro is joint and itis is inflammation. So arthritis is inflammation of the joint. Now it can be any joint in the body. It can be your shoulders, your elbows, your wrists, your neck, your back, your hips, your knees, your ankles, your toes, your feet. Any joint that we have, we can get inflammation and arthritis in it. And we're talking about osteoarthritis with this too. Osteo means bone. And so it's really bony arthritis. So are there different types of arthritis? And the answer is yes. Now, osteoarthritis is the most common type of arthritis in the country. Rheumatoid arthritis is the second most common, and then juvenile rheumatoid arthritis, psoriatic arthritis. And in reality, there's over 100 types and causes of inflammation of a joint. Okay. Now, again, we're going to talk mostly, and what I deal with mostly in my practice is osteoarthritis. Some of my colleagues that are rheumatologists deal with more of the inflammatory arthritises, like the rheumatoid and psoriatic arthritis. So what is osteoarthritis? So what that is at the end of all of our bones, there's a cap, and that cap is cartilage. So sometimes if you look at the end of a chicken bone, there's kind of that white cap over that. Now what that does is allows our joints to roll smoothly. Okay. And when we look at little kids have really thick cartilage caps. As we age, just in general, that cartilage gets thinner, but then it kind of maintains that space. As that cartilage breaks down at the end of the bone, that's when you start getting osteoarthritis. And there's different stages of breakdown of that cartilage. But ultimately, if that bone gets exposed, the cartilage cap wears away completely, bone rubs on bone, and that's what the osteoarthritis is. So again, osteo is bone, rubbing of bone on bone. Degenerative joint disease, DJD, osteoarthritis, all the same, all different names for basically a really painful joint. Okay, so there's an x-ray on the one side. So when we look at x-rays are good showing bones and metal, and that's about it. So when we look at these x-rays, you can see on the one side where it says normal joint space, there's space in between there. On the other side, you can see it's just bone on bone. So the femur bone's on the top, that's our thigh bone, and then the tibia or shin bone's down below. But then as the cartilage wears away, those bones get closer and closer together, and on x-ray we see it grinding bone on bone like you see there. So who gets arthritis? All right, well, it can be anybody. We typically see it more in a advancing age population, but in reality, it can be anyone. Again, we talked about juvenile rheumatoid arthritis, but when we talk about osteoarthritis, it does start affecting more of the older. As we get older, that's where we see more of the osteoarthritis. Now, there's different reasons we get it. Sometimes we can get it with injuries. So a lot of times I'll see patients that have had old ACL injuries. They played sports when they were younger and they tore their ACL, and it just kind of has gotten worse. Car accidents, different accidents. So we see it with trauma sometimes. A lot of times we see it run in families. So we see, oh yeah, my mom had her hips replaced, my dad had his knees replaced. And so we can see that, again, we're talking about osteo, but obviously with some of the autoimmune or, rheumatologic arthritis, you see it as well. But at the end of the day, a lot of times we don't know. Sometimes it's just kind of bad luck, I guess. Sometimes, they say, well, I didn't do anything, didn't play soccer, didn't play any of these other sports, and just lived my life, and now I've got arthritis. So most of the time we don't know. So what can you do to prevent it? Patients all the time say, how do I stop or, make sure I don't get arthritis? Well, if you go to the pharmacy or you go to, the drugstore, you go to a natural, there's all kinds of medications out there that say, hey, you take this joint juice and, all these different juices and pills and stuff, and you'll prevent arthritis. Well, in reality, from a scientific standpoint, none of those have been proven to stop arthritis. Okay, now they may help with some of the symptoms, but we just haven't been able to, if we look back and say, all right, arthritis is when that cartilage breaks down. We've tried everything to prevent that cartilage breakdown or to put it back on, and we don't have science that's proven that any of those things work to do that. This is a patient of mine that was down in Los Angeles. The acupuncture, actually Korean acupuncture, they're Korean, and their acupuncture, a lot of times they'll leave little gold, they'll put the needles in, and then they break off little gold filaments, the end of it. I'm not sure what the science was behind it. But on the x-ray, you can see all those little specks in there. That's actually little gold filaments that have been put in with acupuncture. Well, we ended up doing a knee replacement, and I thought I'd see those little filaments, but they're so small that I couldn't see them on x-ray. It shows up a lot more than you could when you're actually in there. But ultimately, I tell people, buy an anti-gravity bubble. Part of being here on Earth and having gravity is that we walk, and that weight is just wear and tear. And so, or, with SpaceX and some of these things Elon Musk is doing, maybe we'll all live on the moon and we won't have arthritis once we get up there. But for right now, there's not a whole lot that we can do and to prevent it, but take care of our bodies, stay healthy, stay active. But even some of the most healthy and active patients will get arthritis as well. So what are the symptoms of arthritis? What is it when you say, I have pain, I have swelling, I have stiffness? These are some of the things. Then it starts bugging you to sleep. And then ultimately it starts affecting your ability to perform your everyday activities. Nothing that I do is life-threatening. It's not like my cardiology colleagues, if you get a clot in your heart where it's emergent, you say, hey, you can die if you don't get this taken care of. Arthritis doesn't typically kill you, but it affects you from being able to do other stuff. Because of that, your muscles start, getting weaker, your heart and your lungs aren't pumping as much. And, not being able to get out and exercise really starts affecting your psyche and kind of your soul there too. So what do you do if you have those symptoms? Well, first you start with your primary care doc and you go see them. So, this is your primary care team, and then you go see your favorite orthopedic surgeon. Now, I never watched this show because I kind of lived through it with residency, and somebody once told me, they said, he wasn't an orthopedic surgeon. So I apologize for not being accurate on that with that show. But primary cares usually start with x-rays, and we move from there. Now, when on exam, one of the biggest things we can do is say, hey, where does this hurt? I see a lot of patients that come in that say, hey, my pain is in my, points to the guy on the back, that's kind of holding his back there. And they say, well, I think my hip's hurting. Well, hip pain typically is right in the front of your groin. A lot of times people come in and say, I pulled a muscle in my groin, or I had something going on there. And that's kind of where the ball and socket pain is going to be, is straight down on the front. Now, it's okay. I talk to people all the time that come in, think it's their hip, it's their back, or vice versa. Some of my back docs, colleagues, they see patients that think it's their back, and it ends up being their hip. So we always start with an exam and kind of really feel, where is the pain actually coming from? Now, in the hip, the knee, some of these other areas, you say, well, I have pain, but I took, got x-rays and everything looks okay. Other things could be hurt around there. You can have ligaments, you can have tendons, you can have muscles. In the knee, you have a meniscus. In the hip, you have a labrum, or injuries to the bone. You can have different things going on inside that bone as well. So when patients come in here in the office, the first thing I do is I watch them walk. Sometimes you can have a limp, you can have a painful gait. Sometimes you're needing a crutch or a cane or a walker. And then I look at both extremities, because I want to see, if the knee's kind of loose, well, maybe that's just your normal body. I check the other side too, to see how loose that is on that side too. Look at range of motion. We all have been there where it's kind of like grinds or crunches or cracks or pops. So I kind of feel for all that stuff to see what it is that may be causing it. Then we review the x-rays. So this is an x-ray of a hip. On the normal joint space, again, you can see that the space between the ball and the socket is pretty big. That means that there's a good cap of cartilage at the end of that bone. And the page on this other side where it says joint space narrowing, you can see it's hard to tell where the ball is and where the socket is. That's for two reasons. That space is completely gone. What your body does is once that cartilage is gone and it's bone on bone, it says, man, this really hurts. I want to build up some more bone. Well, all it can really build is a hard shell of bone, and it's called sclerotic bone. And that sclerotic bone shows up really white on x-ray. And so that's why you can, it's really hard to tell where that ball is and where that socket is, because there's so much sclerosis and osteophytes. And then this is the x-ray we saw from the knee earlier too. So we'd go through that. So then we talk about, all right, well, what do you do? How do you treat arthritis? Well, there's a lot of ways. So if we talk about, I always look at kind of two buckets. One is non-surgical, and then we talk about surgical options. Non-surgical are things like lifestyle modifications, where you say, okay, well, I used to be able to walk 7 days a week, and I can't do that, but if I walk 5, I'm okay, or I changed the activities I do. I couldn't play tennis, and now I'm playing pickleball, or I'm doing some other things. So, and if that's okay for you, then that's where we start. Anti-inflammatory medications, things like ibuprofen. There's a lot of herbs and supplements, turmeric. There's a lot of things that are anti-inflammatory. I think even on the food side of it, there's a lot of options there. I think some of it that science we haven't caught up with, but I do think that there's some real legitimate medications and foods and different things that are anti-inflammatory. Then if it gets so bad, sometimes some of the pain medications, we try to avoid those if there's a reason, for sure, unless there's a reason. But we really try to avoid pain medications, but sometimes that's necessary. Things like injections, there's a bunch of different kinds out there. Typically, we start with cortisone. That's an anti-inflammatory, try to decrease that inflammation and see how that does. A lot of people think that can injure the cartilage or cause bone thinness, but it typically doesn't. Most of the time, we see that with oral steroids, but with local steroids, we typically don't see that. Most of the time, we can do those shots every about 3 months and not cause any problems. It's variable how much it helps. For some people, it helps a lot and they get 100% relief. Sometimes it's 50%, sometimes it doesn't give much relief. In the knee, there's a viscosupplementation, a gel shot. Some people hear this rooster comb. What that was is when it's made of hyaluronic acid. There's a bunch of different companies that make it, but we're hoping that that rebuild cartilage, because hyaluronic acid is one of the main building blocks of cartilage. And we just haven't seen it do that as much as it's lubricated that knee and allows it to roll smoother. And that's only FDA approved for the knee. Other things that are not FDA approved, but people do PRP and stem cells. So PRP is drawing your own blood and spinning it and taking that platelet-rich plasma and injecting that back in. The goal with that and stem cells is to take these baby cells and say, hey, we want you to decrease the inflammation, help rebuild this joint, help decrease some of that inflammation in there. We use it a lot on soft tissue things to augment ACL injuries or rotator cuffs, tennis elbow. Some of that stuff we've seen it work pretty well too. There haven't been any studies to prove that it works on a consistent basis. That's why the FDA hasn't approved it yet. But there are some studies that show pretty good progress with that. Other things are things like physical therapy, things like bracing, that are all non-surgical. Now, when we talk about surgery, we say, well, when am I ready for surgery? So what we say is when the non-operative treatment options have failed, we've tried non-operative things and those haven't worked. Also, when it affects your ability to do the things that you like to do, really kind of your everyday things. You know, I have patients where they say, I can't even go to the grocery store because it's starting to hurt so much. Or, for some people that's they want to hike the foothills and do, trails. But for some people that's, hey, I want to go hike the soccer fields and go watch my grandson play soccer. And it really hurts to do that. I'm limited in what I can do. Also things like sleep disturbances when it starts waking you up or not letting you sleep. So from a surgical standpoint, how do we treat arthritis? Well, there's a couple types. One of them is arthroscopic, where we go in with the camera and kind of a shaver, and people hear this kind of cleanup. Most of the time, that's for more of a meniscus tear or acute issue. It can potentially help with early arthritis, where you can kind of smooth out those surfaces a little bit. You can do things like microfracture, where you try to get some kind of those stem cells, like what we talked about earlier, from your own body to kind of locally. There's other procedures where you grow cartilage and put that in. Most of the time, those don't work, especially if you have later stages of arthritis. Most studies say that a knee arthroscopy is not a good treatment for arthritis. So, but sometimes early stages buys you some time. Then there's two types of replacements. One is a partial replacement, and we look at the knee in 3 different sections. And so you can really replace just one section if that's the only place you have arthritis. If you have arthritis in more than 1 or 2, 2 or 3, then we talk about total knee replacement. So this is on the knee side. So again, you can see that picture on my screen on the left-hand side, and that's a partial knee replacement. They had arthritis just in one area, so you just replace that end cap on that one compartment. The picture in the middle is a total knee replacement. So with that, what that is a lot of people think that a knee replacement might go in and cut off the whole end of the bone, and it's actually not true. If you look at those pictures, it's more of a cap on a tooth. So I basically just make cuts that mirror that implant. I only put back on what I take off. That implant's only about 9 millimeters thick, so I only cut off about 9 millimeters into the bone and stick that on the end of the femur bone, and then on the top of the shin bone, and in between there is a plastic liner. And that plastic is what rolls on that metal. Underneath the kneecap, I cement on a plastic button back there, and that helps, and that rolls right in the groove in the center of that femur. All right, so if there's questions on that, I can answer those too, but that's kind of the gist of a knee replacement. And then for the hip, what kind of surgical options are there for that? Hip resurfacing and total hip replacement. Now, hip resurfacing, we don't typically do much anymore. This is a picture of a patient with hip resurfacings on both sides. What that was is we would just take off the kind of cap of that and put on a new cap over that hip. The problem is those are metal on metal. Metal on metal became a problem because everything kind of sheds. If you rub metal against metal, you can get metal particles in the tissue around it, and the body's not very good at getting rid of it, and it creates these lesions. Also, we're seeing metal ion levels increasing in the bloodstream and causing problems as well. So we typically don't do this. If there's a surgeon that does it, typically it's for young males as more than anything. So we don't have any problems with reproductive organs. We haven't seen it do that on with males as much as females. So most of the time, if you're having a hip replacement or having issues with the hip, it's mostly a hip replacement. And there's really 4 parts to a hip replacement. On the acetabular side, on the pelvis side, we put a cup inside there, and then a plastic liner gets snapped inside that. Then on the femoral side, there's a stem that goes down the center of the bone, and then there's the neck, and then a head goes on top of that. Most of the time, that's a ceramic ball and a plastic liner. That's the articulation. The stem and the cup are typically titanium, and the bone usually grows into that. So we don't typically cement those in; they're press fit in there, and then bone grows in. So it's a nice tight press fit in that canal. So a lot of times patients ask me about the different implants. Now there's a bunch of them out there. And you say, well, which one's best? Well, it's kind of like cars. You say, which one's better, the BMW or Mercedes, or, some of these cars that are really nice. And ultimately it's kind of whichever one is, fits best in that surgeon's hands, whichever one you like driving the most. And that's what I'd say is find the surgeon that you trust and trust that they're using an implant. They're going to use an implant that they feel comfortable with. And that's the one that's the best one, in my opinion. There hasn't been any studies that say one is far superior than another. That's why there's so many of them. And there's advantage and disadvantage to all of them. But ultimately, I think it's whichever one that surgeon feels most comfortable with. We hear about these custom implants and say, well, that must be better versus just an off the shelf. Well, off the shelf has all kinds of, probably hundreds of different options for you, for your knee, for your hip, for your shoulder. We haven't been able to prove that custom implants are any better than off-the-shelf ones. There's still a lot of research going into it, and there's potential, but the off-the-shelf ones do really well too. Different techniques for knee replacement. You hear about minimally invasive, muscle sparing, balancing, different types of balancing, kinematic, anatomic. And again, I think what you do is you talk to your surgeon and you really feel comfortable with your surgeon, and they'll talk to you about the approaches that they use to that as well. And then to the hip, there's an anterior approach, posterior approach, anterior lateral approach, and there's advantages and disadvantages to each of those. I typically do the anterior approach. I did all those different approaches in the past, but for me, the anterior approach gives me the best options as far as visibility, as far as being able to get those leg lengths right. I don't have to cut any muscle with this. I'm able to move those apart and then and not go past any nerve planes either. And really very few dislocation precautions afterwards, and quicker recovery through this. But the studies at 2 years show that really, no matter the approach that your surgeon uses, most people do pretty well at 2 years. I won't go through this. Is kind of a busy slide. Get you up walking the same day. Typically you go home that same day. Surgery is about an hour and a half or 2 hours. Get you up moving and going on a walker for about 2 to 3 weeks, then a cane for a couple of weeks, then off of everything. We get you into physical therapy right away. For us, we utilize physical therapy or home health physical therapy right after surgery as well. There's obviously risk with surgery, complications with anesthesia, blood clots, pain, infections, leg length discrepancies, dislocations, fractures, nerve damage, all these different things. But they're all very, 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 very low risk. Most of these surgeries people do very well with. The overall success rate for a total hip is about 90 to 95% patient satisfaction. And in fact, it was voted the second highest patient satisfaction of all surgeries after cataracts. So you can't see, and then kind of the blind can see and the lame can walk. Knee replacements, it's a little bit less, about 80 to 90% patient satisfaction. I think there's some different reasons for that. So where do we go with total joints and with arthritis and all these things? Well, and I think on the surgical side, we look at things like robotics. There's a lot of things that are coming out that I think there's some potential with that. Custom implants, advancements in approaches and retraction and all these different things. And, right now things do really well, but I think we're going to continue to improve on that so these things last longer and longer. Now, on the cartilage side of it, I think that in the lab and on science, there's a huge amount of work that's continuing to be done on the stem cells, bioengineering, cartilage regeneration. See if we can get these things, our normal knees to last longer so we don't have to have replacements, which I love doing surgery, but I think if we could figure out a way to not have to do it, would be the best thing we could do. So how to increase your chances of a successful outcome after surgery? Strength. Get as strong as you can, stay as active as you can, and ultimately find the surgeon that you feel comfortable with. It's a heaven forbid one of those kind of negative outcomes happen, but you have to feel that you've chose the right person to do that. Very low risk, but it can happen. And you got to make sure you feel comfortable with whoever your surgeon is. And then really being proactive in your health and recovery, eating right, being strong, staying healthy. Those are good. Now that is all that I have for that. Any questions with any of this stuff? Grace, were there some in that chat there?
Yeah, there's lots of great questions. So I'm going to start at the top. This is a three-parter. I'll ask you the first part first. How do OA and RA affect one another?
If patients have both.
Mhm.
So what rheumatology, what rheumatoid arthritis can do is it is an autoimmune problem that basically breaks down its own joint. So you can get osteoarthritis basically, or what we see on those x-rays is osteoarthritis from rheumatoid arthritis. Okay, so it's basically that degeneration of the cartilage. When we see it with osteoarthritis, it's wear and tear. When we see it with rheumatoid arthritis, it's the body kind of attacking itself and breaking down that cartilage. The end result is the same, where it can be bone on bone, but two different ways to get there. There are patients that have rheumatoid arthritis, but it's controlled with the rheumatic medications, anti-rheumatic medications, but they can still get osteoarthritis because of wear and tear and that cartilage breaking down from that side of it too. So it can definitely happen. I have patients that come in with osteoarthritis, but they also have rheumatoid arthritis, but the rheumatoid portion is very well controlled. So the reason they've got the pain is more of an osteoarthritic joint.
And how does, if someone has both or one or the other, how does osteoporosis come into play?
Yeah.
Arthritis.
Yeah. So osteoporosis, osteopenia, what that is thinness of the bone. Okay. Most of the time that doesn't cause osteoarthritis or rheumatoid arthritis or anything like that, but it does affect when we're doing the surgery. I got to be real careful on how soft that bone is. If you have a diagnosis of osteopenia, but especially osteoporosis, it's really important to get in and talk to your primary care doc, especially, or even your orthopedic surgeon about some of the medications to help strengthen that bone. If you can have good, strong bone before surgery, it's better, just for those implants to sit and stay strong, less risk of fracture during surgery and all that kind of stuff too. But typically the osteopenia and osteoporosis doesn't cause or affect the osteoarthritis or rheumatoid arthritis in a joint.
Mm-hmm. And how could someone make sure that they're staying on top of exercises if they have all three? Like what exercises might be good?
Which exercises? So a lot of times patients don't know, so we'll get them into a round of physical therapy to really help them show, to show them what exercises to do. And also the physical therapists are great at listening to your body and kind of adjusting exercises for you. You don't want to do the exercises, if you've got a bad hip, bad knee, bad shoulder, bad whatever it is, sometimes exercise can aggravate that. So you want to really build the strength around, the muscles around that, without really affecting that. Therapy usually helps with that. A lot of times online, you can find the Arthritis Foundation through that. There's links. Also the Orthopedic, American Academy of Orthopedic Surgeons, there's links to exercises to do when you have arthritis too. But I usually typically start with physical therapy because they're so hands-on with you.
Yeah. Speaking of exercises, there is a tool called the Yes tool on the Arthritis Foundation website. And I believe there's a web version and a phone app version where you could pinpoint which joints are bothering you. And it'll tell you some exercises that you can try.
I love it.
Okay, next question. There is a non-invasive soft wave stem cell therapy that was approved in 2019. Do you know anything about it or how well it works?
I don't. There are so many things that are coming out right now on the stem cell side of things, on the PRP side of things, on a lot of these biologics, like I was talking about. I really feel that that's the future. And approval is a couple different ways. You can have approval to use it, right? Like, so a lot of companies get approval, but a lot of that stuff, gets approved for use, but it's not necessarily approved by, to the point that we're utilizing it a lot in orthopedics. Stem cells are kind of one of them. When somebody has really advanced arthritis, if you look at a lot of the studies, there are studies that show, hey, maybe this helps. And I think PRP and stem cells can help with early arthritis. But once a joint is worn out and you've got later stages of arthritis, there's really just nothing we can do. We can try to treat some of the symptoms, but we've not been able to prove with anything that's come out that I've seen anyway, that helps rebuild any of that cartilage, which I think is the future. But it's not here, not yet today.
Next question is, how effective is viscose supplementation and how long does it typically last?
Yeah, so we can repeat that every 6 months. Interestingly, about 4 or 5 years ago, a study came out, and one just came out recently, where it said, maybe it's only helping about 50% of our patients. So a lot of the insurances jumped ship and said, hey, we're not going to pay for this anymore if it's only helping 50% of people. Medicare actually is one that has continued to cover it. It's usually either a single shot or a series of 3 where it covers it, 1 shot a week for 3 weeks. I would say in our practice, it's higher than that. I'd say 75 to 80% of patients get pretty good relief. But again, we can repeat them every 6 months. It's variable. And I don't know, I don't know why. I don't know if it's a genetic thing, if it's just a wear and tear thing, why some shots, I've got a guy right now that has just terrible, terrible knees, but we're doing cortisone injections. He gets them every 4 months, 6 months, and he does great. He's traveling the world, and he says, I don't want my knees replaced because I'm doing fine on these. So we just keep doing it. I really treat people and not x-rays, but we have great success with it. But like I said, probably about 75% of patients in my practice get pretty good relief, and meaning that it usually will last about 6 months.
Mm-hmm. Great. This is just like me thinking out loud, but when should someone think about seeing a specialist for joint pain?
Yeah, so what I would say is you typically start with your primary care doc. And what you don't want is, again, this is more, people say, well, this is elective, orthopedics. And it's not really elective in the fact that if you have a lot of pain and you can't do things, then all of a sudden it starts affecting the rest of your body. So then it becomes more of a medical issue. People gain weight because they can't walk, or their muscles fatigue, their heart's not pumping, their lungs aren't pumping. And so if you're having something that's limiting you from doing something that you want to be able to do, that's when I say you start that ball rolling. Find out what's going on, get some x-rays, things like that. Some primary care physicians are very comfortable with doing all that workup that's non-surgical. Some aren't. Some may say, hey, you know what, I want you to go to a specialist right off the bat. And that's totally fine too. But that's usually what I'd say is when you start feeling, pain where you say, hey, I used to be able to, brush my hair, and now I'm not able to do that, or I'm having a hard time brushing my teeth, or even, bringing the fork up. It's probably time to just get your shoulder looked at, start from there. People are scared. Hey, I go into a surgeon and they're going to do surgery. Most of the time it's not. Most of the time we can try, or not, at least that's not our first line for sure. We're trying to make sure we can try things that are non-operative, and then we go from there.
Awesome. Is it standard to recommend physical therapy after shaving a torn meniscus?
Yeah, so usually what we do is we give you about a week of not doing a whole lot, and then get you into physical therapy after that. Because arthroscopies, meniscus surgeries are still surgeries. I would say the only one the only surgery that's not a big surgery is one done on somebody else. People say, oh, it's just a minor surgery. I'm like, it's not a minor surgery. Any surgery is not a minor surgery. So yeah, but we get pretty aggressive with physical therapy just because we want you to get back strong 100%. Now, there may be surgeons that say, hey, you don't need physical therapy, and here's some exercises to do. But in our practice, we do.
Perfect. Is chiropractic care more beneficial, or does it just depend on the person?
No, I think there's a huge area that chiropractic work can help. With hip and knee arthritis, I don't see it, obviously I don't see it working as much. Low back, neck, and acupuncture, I guess I didn't put a whole lot of that in there, and I should. I think there's a lot of place for those things, I guess non-traditional or types of care. I think that, I know a guy that had acupuncture, has had shoulder pain, ended up with acupuncture in his shoulder, and really has not had any pain in his shoulder since. I think there's a lot of patients that I have, and friends for that matter, that go to chiropractors on a frequent basis for adjustments and for their alignment. And I think that there's a place for that. I think in reality, all these different types of medicine or traditional or non-traditional medicine, I do think there's a place for it. I think as long as we stay within our realm. I mean, for me, doing hip and knee replacements, I don't do anything with the heart because I'm not a cardiologist. I leave that to them. I think the same thing with chiropractors, as long as, we kind of all stay in our lanes and know what we're good at and know how we can help, then I think there's a benefit to all that.
Great. That was the last of the questions. Does anybody else have anything that's on your mind? Feel free to type it in the chat or come off mute real quick. Looks like that might be it, Dr. Jamieson.
I answered everybody's questions, so I did my job before they even had them.
You more than did your job. We're so lucky to have you with us. Thank you so much for your great presentation. I think I can just tell by the quality of the questions that were asked that it was very engaging and is definitely very valuable. Like I said, we're being recorded, so I'll send out the link for everybody afterwards. If you have any follow-up questions or anything that you might need that the Arthritis Foundation might be able to help with, please don't hesitate to reach out to me. My contact information will be, you probably have seen many emails from me by this point. Feel free to reach out at any time. And we hope to see everybody again at the open house in September and integrative medicine talk in October. And again, thank you so much, Dr. Jamieson, for spending your time with us and sharing your knowledge. We hope to see you with us again soon.
That was my pleasure. Thanks so much for the opportunity. It's really fun. I love what I do, so it makes it nice. But thanks for this opportunity. Thanks to the Arthritis Foundation for doing this. This is great.
Perfect. Thanks, everybody. Have a great night.
Thank you all. Have a good night.
Thanks so much.
Thanks, Anna.